Thank you very much, and thank you for making me a part of this webinar. What I'm going to talk about is, as Ms. Divya said, a little away from the technical aspects. It is about ensuring safety in biometry. So we know that cataract surgery with IOL implantation is the most common surgery done worldwide and with the best success rates. And not only we surgeons, but even the patients know that it's very successful, and therefore the patient expectations are very high. And they need a good vision for all activities and expect a certain amount of spectacle independence. Now imagine that in such a case, we do an excellent surgery, but put in an IOL power which is wrong, which belongs to some other patient. Then this negates all the benefits of the excellent surgery that we have done and leaves behind a dissatisfied patient, and the patient would lose trust in our hospital or in our services. So what can go wrong with biometry? It may so happen that the biometry may be done for a wrong patient. Instead of patient X, we may measure the eye of patient Y and take it as the IOL power of patient X and implant it. We may do the biometry for the wrong eye. It may be the right eye which has been advised, but by mistake, we measure the left eye, put these measurements as measurements of the right eye and implant that IOL. It goes wrong. Wrong IOL power calculations can also happen by choosing a wrong lens status, like not choosing the phakic or the pseudophakic modes, about the vitreous, like with silicone oil or with laser vision correction being selected for calculating the IOL power. Also, wrong A constant can get chosen for, it may not be for that particular IOL. There can be wrong target refraction, which may get selected. There can be axial length calculation errors if the patient is not positioned properly or the patient is not fixating properly, and we saw that in the first talk. There can be transcription errors in the documents, or an IOL different from one which has already been implanted in the other eye can be chosen. Like there may be a multifocal in the other eye and we may choose a monofocal or vice versa. And we may miss to repeat the biometry wherever it is indicated. So these are all things which can result in a wrong IOL power being implanted. So to ensure the correct patient, what we have to do is to establish patient identity. And this was touched upon in the first talk. We need at least two identifiers, the name and the unique number which is given in the hospital, the relative's name and address. We should always ask open questions because we are dealing with vulnerable patients with some blunted faculties who are maybe even hard of hearing or may not be able to understand what we are asking. So we need to ask open-ended questions. We need to ensure that we are going to measure the correct eye and highlight the IOL power of that eye. We have to check the case sheet for the doctor's advice and to check with the patient the eye to be operated. And in case there is any discrepancy between the patient's expectation, we need to recheck the advice and again explain to the patient why what he is expecting is not being operated upon. And we need to make it very clear that this is the eye to be operated. For ensuring correct IOL calculation, we have to calibrate all instruments regularly. Again, this was seen in the previous talk. Choose the correct lens status, whether it is phakic or aphakic. Choose the correct vitreous status, especially if it's a silicone filled eye, and we saw what correction needs to be applied for that. Choose the correct laser vision correction status, whether it is LASIK, PRK, RK, and whether it was a myopic or a hypermetropic correction, and use the appropriate formulae or use the worksheets. Choose the correct constant. Here again, it should be the A constant for SRKT, the surgeon's factor for Holiday, or Barrett has a lens factor. So we have to choose the constant according to that. It should also be according to the mode of biometry, as we saw Dr. Ramesh's presentation. It differs between ultrasound and optical biometry. It differs among races. So we need to look at that. And we need a constant which is according to the IOL which is selected. Patients desire spectacle independence, and therefore we may change the target refraction from one patient to another while we are trying a micro or a mini monovision. Myopic patients would prefer to be left a little myopic so that they can read well. Now, in these cases, after changing the target refraction, if we forget to revert back to the default target, then we can get a wrong IOL power for otherwise normal patients. So we have to make sure that the target refraction chosen is correct for that patient. We have to ensure that the measurements are correct. We need to have the correct placement of the patient, like supine for an immersion. We have to ensure patient fixation. And we have to ensure that there is a correct mode of measurement has been chosen, like in the A-scan, to change it to the immersion mode if you're using the immersion. Selecting the correct IOL, as I said before, the other eye is operated. We should verify the case records if available as to what model and what power of was implanted in that eye. And biometry is always done for both eyes. So note what was the IOL power and readings in that eye at that time during the previous surgery. And this time also it should be close to it. Possible errors, as I said before, we can, we can advise a multifocal in the case of monofocal in the other eye or vice versa. Now, repeating the biometry when indicated is very important. These are known as the holiday criteria. So we have to repeat it on 2 equipments and or 2 biometrists if the K reading average between 2 eyes is more than 1 diopter. If the K reading is more than 47 diopters, that is steep, or less than 40 diopters, that is flat. If any eye shows an astigmatism of more than 4 diopters, and if we get variable readings because of the corneal epithelium having punctate erosions or a dry eye. If the actual length is less than 22 millimeters, that's a short eye, or more than 25 mm, which is a long eye. Variable or borderline readings keep happening with the actual measurements, we have to repeat it. If the difference between 2 eyes is more than 3 mm, which translates into almost a 1 diopter difference between 2 eyes, we have to remeasure. The IOL difference between the 2 eyes is more than 1 diopter. If the IOL power of emetropia is more than 3 diopters than expected, and in post-classic cases, ideally, if the patient has been emetropic, the power should be between 20 and 23. But if it is less than 20 and more than 23, we need to remeasure again and make sure that this patient had some regression or not. We can avoid transcription errors, and the possible situations are when there's an advanced cataract and you have started measuring on the optical biometer and you shift the patient to ultrasound. And when you transcribe these values to the optical biometer, there can be mistakes. Transcriptions are also necessary when we're doing toric calculations in the manufacturer's website. And again, transcription of data would be necessary for online formula usage like Barrett's and in post-classic. Ensuring correct documentation, we have to make sure that we are legible with the numbers that we write. We have to handle 1 patient at a time so that we don't enter other patients' data. There should be an immediate verification, preferably by another biometrist or by the doctor, from all the records which are present. You can see here that it's from the A-scan machine, it has been copied onto a seal, and each of these digits are written in a separate column so that it doesn't get mixed up. And there should be a verification of the printouts. And finally, we should ensure that all the records which are attached belong to the same patient. Like you see here, these printout from the A-scan or the optical biometer and the printout from the toric calculation and the counseling card. We have to make sure that all of these belong to the same patient and the patient is carrying his own record. So all these will ensure that we implant a correct IOL. So to sum up, biometry is the most vital step in ensuring a perfect visual recovery of the patient, and safety errors should be avoided at all costs, especially in implanting the IOL power of correct IOL power. And care during biometry goes a long way in ensuring patient satisfaction. Thank you very much.